All right. Well, great. Thanks very much. I really appreciate the opportunity to speak with you today, and I know we're going to have a chance to get questions later. So it's actually great for me to hear Jason and Courtney actually speak as well, because we talk informally, but it's informative for me to hear what you have to say. So I'm going to give you a little bit of a, I think Kate actually, or as Yumi asked me to cover neurosurgical aspects in 30 minutes. I'm not going to be able to do that. I'm going to focus on one area, and I'll try to give you some high-level thoughts on some of the other areas. So disclosures, there's some consulting agreements, but no overlap with this presentation. So as Courtney said, why is this interesting? It's interesting because it's common. And a lot of pediatricians will never end up seeing a patient with a neurosurgical problem, or very infrequently, but this is probably one of the intersections between pediatrics, rehab, obviously ortho, urology, that all of us sort of see these patients together. I'm going to talk a little bit about nomenclature, but this is like such a total mess because people call these things different things. And this is true in the literature, it's true in the radiology report, it's true in all of that. And it just makes conversation much more difficult. So I try to avoid a lot of the nomenclature. Spina bifida is a lay term. It's not a technical term. When people use spina bifida as a lay term, what they're talking about is myelomeningocele, which is the severest form, and that's what we've been discussing. But what I really call spina bifida is actually spinal dysraphic states, which means all of these abnormalities that result in abnormalities of the spine and or spinal cord. I list these terms only that I don't want people to get bogged down with them, quite honestly. Jason gave the term spina bifida occulta. That's a radiologic term that refers to that split lamina or the split spinous process. And Jason's absolutely right. That doesn't really have any functional significance. Neurosurgeons, however, refer to spina bifida occulta, and I'll tell you what I mean by that, as all closed neural tube defects. And this is what I mean by how people talk about things in different ways. So I try to basically think about it of all of these broader group of conditions in two groups, and I'll tell you why. So spina bifida occulta it means hidden, right? Occulta means hidden, and it's a pre-imaging term. Things were hidden because there was no way to look inside the patient at that time. And what they really mean by occulta is these are all closed neural tube defects. And what do we mean by closed? Closed means there's skin over it. This is what pediatricians learn early on, right? These are the 5 cardinal, manifestations: the hemangioma, the dimple, the deep dimple high up, the mass, the lipoma, the appendage, and the hairy patch, right? So those are the 5. The skin is closed over this, and there are lesions underneath it. If you see any of these things, there's a very, very high probability there's something going on in the formation of the spinal cord. And neurosurgeons refer to these as occult, okay? Now, the important thing about these is that there are varying kinds of abnormalities of the spinal cord, but all of these, in general, the neurologic deficits are much, much milder than what you see with true open neural tube defects, and that's what I'm going to talk about later. The second thing, which is really important and why I focus on separating these into the closed and open neural tube defects, is that, and this is something we've learned, in the last sort of decade or so, the developmental abnormality is what's affecting the cord, okay? And as Courtney said, it happens super early, right? So that in humans, we actually think that the neural tube is closed by 28 days, right, after conception. So that abnormality, whatever happens to the cord at whatever segment, that's the primary abnormality. That's what gives you the weak feet. That's what gives you the bowel and bladder dysfunction. The secondary abnormalities are the things that affect the brain, the Chiari, the hydrocephalus, all of that. These occult or closed neural tube defects don't have any of that for the most part. So it's very important conceptually to think about the closed defects as involving the spinal cord, and those deficits are often quite mild, maybe a little calf weakness, maybe a little bit of a club foot, maybe a mild neurogenic bladder, but those kids are very, very functional. And we do see them in the spina bifida clinic, but often we don't because their deficits are so limited, and they don't have the brain abnormalities. Okay. This is an example of one. I think Courtney showed a picture of this, or Jason may have as well. So spinal cord lipoma, and people use a lot of different terms for these, which I find completely confusing, so I don't use them. Okay, so I just call all of these spinal cord lipoma because it's descriptive. It tells us what's going on. This is the kid with the lump in the back, skin covered. The fat extends from the subcutaneous tissues down into the spinal cord, and this is a later defect. Okay, so the spinal cord is actually formed mostly, but there's a connection from the fat down to the cord. The spinal cord is actually very functional. Most of these kids are walking. As I said, they may have some mild weakness. This is what it looks like in the OR. There's that subQ fat. We expose it. It goes all the way down to the cord. This is a, quote, tethered cord. It's tethered because it's tethered to the fat. What we do at surgery is we detach that fat. And we'll talk more about what that means in terms of retethering. But that's basically those group of conditions. They're less common than the open neural tube defects. Okay, so the old historical term is spina bifida aperta, or open, and that's what I call open neural tube defects, of which myelomeningocele is the most common, but there's others as well. All right, and this one is the one classically we talk about. You know, the neural tube hasn't closed. It actually hasn't not only just closed, it hasn't folded, it hasn't patterned. All right, so this is from first year, first month of medical school. Everyone forgets this, right? So this is a neural tube. You know, we call neural tube closure, but I'm going to show you a picture of a myelomeningocele, and what it actually is the first part of that cartoon on the left, where the neural placode, right, which is what will become the cord, never folds, never shapes, stays as a flat disc continuous with the skin. So actually the patterning that causes myelomeningocele, I told you that neural tube closes by 28 days in humans, but the early patterning is actually in the first week. And that's actually where the actual deficit or the defect is in myelomeningocele. So this is a newborn. What you're seeing is, so this is an open neural tube defect, meaning that the neural tube is this, in the center of that sac, which is filled with CSF. There's that flat structure, and I don't know if you can you see that arrow? So that flat structure right there is what is the neural tube. And it hasn't folded, it hasn't shaped, hasn't patterned. And that's why these kids have deficits, because their cord is functionally at the 4-week stage. Okay? And those of you who are paying attention to Jason can see even at this point, this kid has a patulous anus, right? So rectal tone is not present. Has atrophy of the legs, right? The muscle bulk is markedly reduced, especially in the calf, and has club feet. Right? So this is the primary abnormality, and then they have the secondary things, which are all the other things that we also have to deal with. Okay. I'm not going to talk about folic acid. Courtney talked about that. So why do we operate on these early? And I do a lot of prenatal counseling, and I try to emphasize very clearly the purpose of the surgical repair postnatally is not to improve function, right? It's to prevent infection. We know historically that if you don't close these, 50% of kids will die of meningitis, okay? And that's because the neural tube is open. So once you take the kid out of the sterile uterine environment, they'll get a meningitis, about half of them, or 2/3 of them, and half of them will die. So the purpose of surgery is to close the skin so that they don't get an infection. Okay. I'm going to talk about that a little briefly later, but we'll discuss it in a second. So these are the secondary things that happen in the open defects. So hydrocephalus, the Chiari malformation, and then there are these other things that happen with respect to tethered cord, but also these other abnormalities of the brain. And we think that all of these secondary things happen because the neural tube and the CSF pathways are open to the amniotic fluid, and there's a pressure differential, and that problem early on causes those brain abnormalities. And when I was talking about closed defects, the reason they don't happen in closed defects is because you've got a skin layer over it, and so you don't have communication of CSF with the amniotic fluid. Okay, I'll show you very briefly one slide at the end. What the fetal intervention has taught us is that the secondary abnormalities happen after the primary ones, because the randomized fetal intervention trial showed us that the secondary abnormalities like hydrocephalus, Chiari, those are reversible. Not all of them, but a fair number of them are reversible if you intervene early enough during the pregnancy, 24 weeks or so. Okay. And these are all the secondary abnormalities associated with open neural tube defects, and this is exactly why we have Spina Bifida Clinic because this is the constellation of things. One of the things I counsel moms and their partners is if you take 100 kids with L4, okay, same level, and you know they're going to have ortho, urology, neurosurgical problems, what's impossible to predict is the relative balance of those. And what I mean by that in concrete terms is that there are some kids, we'll put a shunt in them, and I see them once a year in clinic and they're doing great. Like maybe they have one revision, but it's a social visit, I don't have to talk to them again. But they've got tons of problems with their club feet or their problem. They're seeing, Jason or his colleagues continuously. Or they're seeing urology continuously because they got high pressure bladder, they can't be managed adequately, they need augmentation, those kinds of things. Fortunately, it's the rare kid that has a ton of problems with each of those things, all right? But what's really, really hard to predict, and that's why that individualization is super important in clinic, is that each kid will tend to have a cluster in one of those areas that you really have to focus on. And that's almost impossible to predict. It's impossible to predict prenatally. It's also impossible to predict in the immediate postnatal period. I tell families that they're like, and I was laughing well, not laughing, I was recognizing that conversation, will my kid walk? Right, and I said, I'm not going to be able to tell you that, and when your kid's like a week old, because week-olds don't walk, right? And I can't tell you that. Usually they're going to have a delay in ambulation. They're not going to walk at 12 months. So I said, look, we're going to have a pretty good idea at 12 months, but if you're asking me about functionally what your kid's going to do, we're going to have a really good idea at 2, probably 3. Okay, but it's really hard to know that off the top of the bat. Okay. We don't have great outcome studies in these populations. Okay, I find there is outcome data, but it's actually shockingly not great. There are some old studies, and I pulled out a few of these just to show you that I don't think the results are as bad as they are in these slides. But this is a cohort of 200 patients. It's not terribly old. It's like 25 years old or so. But they had a mortality rate of 15 kids out of that 200, like 7 or 8% mortality, and this is just during childhood. There's another cohort from a group up in British Columbia that had a mortality rate, older cohort of 18%. So this is not a benign condition because they have chronic medical problems that intersect and lead to significant cumulative morbidity over their lifetime. This is a study, I think, from a group in Europe that described adult patients, and it just sort of lists their sort of chronic sort of morbidities. And as I said, some of these are well managed. Some of them can be very poorly managed. We have patients in wheelchairs who are great, like they get around, they're very mobile, they're very active, but then other kids who struggle, with that same kind of deficit and disability. Life expectancy. So this is another conversation I have with families, and I think a lot of the older data overstates the decrease in life expectancy. And I think I tell families now that with good medical care, preventative medical care, a child with spina bifida in the current era should probably live a normal lifespan. Obviously, a child that's going to have multiple, complications with a specific kind of area. So, for example, in my own area, kids that have multiple shunt failures, episodes of shunt infection, et cetera, they're not going to have, on average, a normal lifespan. But a child that has well-managed chronic medical conditions is likely to have a near normal lifespan. Now, I'm obviously, if you're attentive, it's another struggle, huge struggle, is delivering an equal level of care, right, to all of these patients and families. And there's a huge variation in what level of care these kids experience. So hydrocephalus, I'm not going to talk a ton about it except to say that on average, about 80% of kids who have postnatal repair will require a VP shunt. VP shunts are they're a great tool because prior to them, kids used to die from hydrocephalus, but they have I tell people they have a huge carrying cost, meaning that if you have a shunt, it means a lifelong surveillance, lifelong supervision. And one thing we don't fully understand is it the hydrocephalus that causes that long-term impact on function and disability, or is it the complications from having a shunt? Okay, because those kids are going to need, we did a study years ago that looked at kids that are shunted at birth and then followed at 18 years of age. On average, the mean is about 3.5 procedures until 18 years of age, but that can go anywhere from 0 to 20, right? And those kids, obviously, they're going to have 20 shunt revisions. They're not going to have the same functional, outcome. All right. I'll skip through that quickly. So what do we do in terms of hydrocephalus surveillance? The kids that have shunts, we, in our clinic, we try to follow those kids at least once a year. And that's often through Spina Bifida clinic, but sometimes it's outside of that. The main things, a kid that has a, overt shunt failure, they're throwing up, they're lethargic, that's not a diagnostic dilemma, right? I mean, that's not something you're gonna, worry about. The things that we do worry about, though, are kids that have shunt malfunction that are partial shunt malfunctions, or kids that have a shunt. Most hydrocephalus is not, the misconception is that that you're not absorbing any fluid. That's incorrect. Most hydrocephalus is a discrepancy, meaning that you're making a certain fixed amount of CSF. You're able to absorb 80% of it, 90% of it, but you're not able to absorb 100% of it, and that's what the shunt does. So one of the things that we counsel families to look for is, if you're getting a kid who has a plateau in cognitive, like they're doing okay, and then they start leveling off in school, we want to know about that functional decline. There could be other reasons for it, but it also could be because they've got a partial shunt failure going on. I always try to get them to have yearly ophthalmologic optometry exams. I don't worry too much about whether there's a pediatric ophthalmologist, whatever, it's too hard to get in to see them. I say, it's more important that you have an optometrist or ophthalmologist in your community that can follow your kid on a yearly basis. Shunt problems, visual problems are very, very early sign of that. Okay, so those are some of the important things that I look for in kids in Spina Bifida clinic, and the cognitive assessment is super important as well. One comment about that is that 80% end up with shunts, but 20% don't. And a lot of those kids will have ventricular enlargement on their scans, but they won't have overt signs of hydrocephalus, like they won't have papilledema, they won't be throwing up. And the problem we run into in those kids is that, I think as Courtney mentioned, on average, kids with Spina Bifida have about a 10-point IQ difference on their mean, is about shifted over about 10 points. 8 to 10 points. So what's really hard to figure out is it in the unshunted kids, is there, could we benefit from a shunt placement in terms of cognitive function, or is that just simply their performance level? And that's a very complicated question that, sometimes we end up placing a shunt in slightly older kids to try to get around that. Okay. Jason alluded to this, so I wanted to talk about tethered spinal cord because it's really one of those areas that I find frankly very challenging. So there's a kid with Spina Bifida at birth, and then 20 years later on the MR, it doesn't make any sense, that MR, because she was so twisted in terms of her scoliosis, but she has a cord that's attached because all open neural, in other words, all kids with myelomeningocele that have surgery at birth, when you do an MR scan of them down the road, all of them have a tethered cord by imaging. Okay, the radiologist report is always going to be the same, right? Spinal cord is low, spinal cord is attached to the site of previous repair, consistent with tethered spinal cord. Okay, that's all the reports are going to say the same thing. However, the clinical diagnosis is the more important one. Okay, meaning that what that kid's function is, and that change in function, what Jason and Courtney mentioned, that delta, how much, what are they doing in terms of their change in function is what drives decision making. Okay. This was one study from actually one of my former partners, Corey Raffel, when he's at the Mayo, and they looked at a small group, 45 patients, and 40 of them ended up with additional procedures for tethered cord, a quarter of them by a year of age, 40 by 2 years of age, and 60% by 5 years of age. I think their cohort probably overstates that to some degree. I don't think my experience has been like that, but it's certainly something that we consider as these kids get older, is whether to do an untethering procedure down the road. I think Courtney mentioned this a little bit. So it's rare for infants, so let's say the first year of life, for us to need to do a retethering procedure in them, because often The clinical change hasn't happened, but where we see it is that if there's a dramatic change in urinary, so for example, they're cathing, everything is going well, but then they start to get very high pressures in the bladder. Okay, and then sometimes that's an indication for it, but it's unusual. The other thing are very rapidly progressive foot deformities without any other obvious explanation. The younger children, so let's say 2 to 5, 2 to school age, 2 to 6, 2 to 7, these are tough because they can definitely have a plateau in function, whether it be motor function, bladder function, and the question is what is causing that? Is it that they've doubled their weight in the last 2 or 3 years? Is it actually because of untethering? And that pattern of change in young kids is, as I said, very much of a challenge. So why don't we just untether all of them? The reason is because there's probably about a 10 to 20% incidence of making those kids worse. Okay, we're going to operate on the spinal cord that's already not normal. There's a bunch of scar tissue. We're going to release it. We're going to make some of those kids worse. Okay, and then we're not doing anyone any favors in that situation. So we really want to see if there are objectives for surgery line up with what the patient wants and what the rest of the team is considering. Teenagers are different. They tend to have a little bit more higher likelihood of pain, changes in bladder function, and spinal deformity. So if we see a kid with rapidly progressive scoliosis, and we'll consider doing an untethering procedure prior to their deformity correction, or even earlier than that if need be. Adults are a particular challenge. They often will have neurogenic pain, and it's a really difficult problem. I'll briefly mention that is that I work with some of the adult neurosurgeons up at the Parnassus campus and these patients, and it's a really unsatisfying procedure at that age because I think the problem is that the symptoms they get are a consequence of their lifetimes, 20, 30, 40, 50 years of that structural abnormality. And operating on them often isn't, you can help some of them, but a lot of them you're not going to help. Okay. I'm going to skip over that. So what do we do in terms of it? I think you've heard it already, that sort of reliable, really very good clinical exam and history is the most important thing that defines the indications for surgery. The other things that can help, the urodynamics I find are very helpful from our urologists in terms of looking at things like bladder pressures, changes in the neurogenic bladder. Imaging, frankly, is not that helpful. We get imaging, but I don't find it's the major thing that affects decision making. And a little bit less so the neurodiagnostic, EMG nerve conduction studies I find very difficult to interpret in this population. Okay. Let's see. We talked a little bit about those problems that happen. I think the most compelling reasons for surgery in this indications are really if they have a progressive deficit that you can attribute to it. So, and this is important in a child that has exactly what Jason was describing, that mid-lumbar, they're ambulating, but they're losing a level. Like if you're a S1, you lose a level, it may not have a big impact on your function. If you're L4, you're losing a level, it may have a huge impact on your function, okay? Similarly, if you're a high lumbar, you lose a little bit of strength. We're not gonna, we don't want that, but it may not be enough to push us into doing surgery. Pain is the other one, as I said, in teenagers, young adults, and it can be very debilitating, so we obviously involve pain management and try to see if we can manage pain in a conservative way, but sometimes that pain can be so limiting and obviously very, very damaging for their day-to-day life that's a reason for it in the older kids and young adults. Okay, spinal deformity, I'm not going to spend too much time on. It's a challenge just because of the reasons that Jason said. There's a combination of a neurologic structural abnormality plus the deformity. Okay. Okay, so I'm not going to talk a ton about operative treatment. The only thing I did about this is that in the older young adult, older kid population, we're looking a lot more at this option of what's called vertebral body resection. And if the whole idea, the concept between tethered cord is that you have this cord that's attached in a baby, the kid grows, and you have the tension on the cord. That's sort of the simple way of thinking about it. It's probably not all like that, but the preliminary going back and operating on these patients again and again is simply not a great long-term strategy. There's some preliminary data that suggests that if you can actually shorten the spinal cord, and we're not talking like inches, we're talking like, usually 2 centimeters, 3 centimeters, you can actually have a pretty dramatic impact on symptoms. It's a big operation, but the preliminary, evidence, at least in that young adult population, is it's superior to actually the untethering procedures. So, okay. I always think that conservative management is better in these patients, and the treatment decisions have to be designed around functional. What are you gaining? When you're trying to accomplish this surgery, and the realistic expectations are crucial. I'm going to reiterate having that conversation with colleagues, rehab, ortho, et cetera, to make that decision. I throw this slide up because this is a huge problem, right? This is true with everything in the peds to adult transition. It's hugely complicated in these patients with chronic disabilities. And I'm going to shout out the urology group that have done a very, very good job of this, actually. So Hillary Kopp, who's one of the peds urologists, she has a colleague on the adult side, Lindsay Hampson, and they have a clinic together. And so they see these young adult patients, and they gradually transition over to adult urology, which I think is fantastic. And I feel badly that we don't do that in neurosurgery. We don't do a great job of that in the spine area. And certainly in terms of medical care for these patients, that's a huge hole, which I think is a challenge for us to address in the future. Is there positive stuff? Absolutely. So what I mentioned to you briefly is that, so fetal intervention, so, it's an accepted intervention, and the primary problem in terms of the neurologic deficit in the lower extremities, that's not something I think we can immediately reverse. One of my former colleagues, Diana Farmer, who's a ped surgeon, is chair of surgery at Davis. They have a clinical trial that's ongoing now that's using stem cells placed at the time of fetal repair to see if we can actually correct some of those deficits. So that trial is ongoing. We don't have results on that, so I think that's an interesting path forward. The fetal intervention study that I was part of, there was a number of outcomes, but the rate of hydrocephalus was reduced by about 50%. This is a typical Chiari malformation. This is a slide from a patient that had fetal repair, and you can see the Chiari is absent. So this is, to me, at least pretty compelling evidence that a lot of the secondary abnormalities that occur in spina bifida that are a big problem for us are actually those things that happen in the second trimester and third trimester. There's an ongoing clinical trial right now that's being run by Hydrocephalus Clinical Research Network that's looking at a surgical technique to do what's called a third ventriculostomy, which is kind of like a detour procedure, but also ablating endoscopically the choroid plexus. The goal there is to see if we can avoid the use of shunts in these patients. This is an NIH-supported study, keep our fingers crossed, and it's recruiting patients that are randomized between the standard treatment plus this to look at long-term outcomes. And they're about halfway through recruitment, so I'm hoping another couple of years that study will be finished recruiting, and then a 2 years follow-up after that. So, okay, I'm going to stop there. We're out of time, so happy to take questions as well.